All right, you there, Sam?
Yep.
All
All
right,
right,
this
Mike.
is Dr. Michael Wasson and Dr. Sam Bobek, the amazing Talking Jaws podcast that we're throwing together. What are we talking about today? Lefort one?
I think Lefort osteotomies, you had a case that you're about to start in on. We had warmed up our talking prior to the record button. And this was a low angle skeletal class 3 teenage person,
No, mid 30s.
30s.
Mm-hmm.
I'm getting old.
You are.
Um,
Well, some background because this is what I was going to tell you before we hit record about this case. So she may not make a huge difference, but she has these massive buildups on her first molars on both sides that I clipped off in Dolphin. So that's part of why her bite is showing as it is, because if she doesn't have on there, she dramatically contacts her incisors. So the orthodontist
sure.
put buildups on there. So those are probably clipped off, but not entirely accurately. And before we started hitting record, you said you don't think she needs reduction genioplasty. Why do you think that?
Oh yeah. I mean, I think clockwise is going to be enough for her chin. Chin setback is going to widen her out. It's going to broaden her chin. I would, if anything, just reduce it. Just like,
Just burn it down?
um, I mean, can you rotate her head around a little bit?
Yeah. What do you
This
want
is
to
a
say?
live thing, right?
Yep. Hopefully
And then tip it down. What's
this
going
way.
on? Did she get her zygomas removed? I was kidding. Yeah, I mean,
Sinus.
because her occlusal plane here is what, 9 degrees? What do you
That
measure it
because
to?
of the buildups, it wouldn't even give me an accurate measurement. It's probably more than that.
I mean, it looks fairly steep. I mean, I can't tell with head position. But I mean, I think you're right with clockwise, and there'll be enough chin rotation backwards that I'm not sure you're getting much out of setting the chin back 2, 3 millimeters. But
Yeah, it's about, but I think it's like 3.25 setback in this image. Mostly what I did for this because it was a preliminary plan. She's not going to have surgery for months.
yeah,
Was just trying to show her, you know, for anyone who actually is dumb enough to tune into our podcast video, if we do it, it was just to kind of show her what do all of these movements mean for your soft tissue changes, because
yeah. I
it's
mean,
that
it's
worse.
a complicated thing, and I think that's a good way to demonstrate it because um, I think certainly in the patient online community they talk about millimeter movements as if they're uniform. And when you start changing pitch, that starts throwing people off because of the standardized pitch rotation of the central incisors. How that moves things starts becoming not intuitive. Um, and so I think from a patient standpoint, other than, looking at her profile and maybe not liking that, it's a good visualization tool, especially when you go over to the movie and rotate it back and forth, right?
Yeah, I still got to figure out the whole movie thing, make it a little bit better and more presentable. But yeah, you can.
What's oh, you're on present. Can't you just go to post?
The what?
Oh yeah, you're doing the right thing. But yeah, we're supposed to talk about upper jaws, I think. This overall clockwise plan. Let me ask you, this game plan, what are you thinking? Doing Maxilla first here, or you doing Mandible first?
Well, as we've discussed, I try to do mandible first now, unless I have a specific reason not to. So I'd probably look at my splints, and unless there was a reason why, I'd probably still try to do mandible first, even though it is a decent rotation. And I'll probably end up rotating her a little bit differently, but I don't know. Do you think it matters too much in this case, and why?
I don't know. I would entertain the idea. I mean, I'm like you in that I like Mandible first. Mandible first is going to give us a bit of a wonky intermediate splint with clockwise rotation. And she has those bumpers on the sixes. And I'm always concerned about a difference in the orthodontic plan position versus the actual surgical position. Showing up in the OR and having no bumpers. Uh,
I plan on
I
having them
would
removed. You leave those on sometimes? I try at all costs to get those off.
Oh, sure. But don't you think that the two positional change, and then there's the practical nature of why the bumpers are in there, which is she's not biting off her brackets, right? So it's not going to give you a ton of time without bumpers, and the vertical position of the those teeth are important in mandible first because those will be your first contact, right?
Yeah, but you don't think, I mean, my plan would be have orthodontic appointment shortly before her pre-operative planning appointment, get those removed. So we're talking 1 to 2 weeks, hopefully. Get her hooks and everything put on. Come to my office, scan, plan,
Yeah,
get
but I mean, this is a
that.
situation where I'd entertain Maxilla first. I would definitely entertain it. If it's one of those bites that you think it's solid and it's not shifting much, I don't think it hurts to do the Maxilla first. I mean, because at least for me, at least in these situations, with mandible first, I'm prone to do less clockwise than my plan is. Like I'll have more counterclockwise than I wanted to.
Really? Okay.
Well, because generally there's going to be inaccuracy of seating the molars, right? And embrasure wires sure help with that, but um the trick, given the bumpers and the pitch change in mandible first, I just worry about cheating on the side of carrying out the plan. So if her
Yeah,
bite
I hear
was
you.
fine, I would lean towards Maxilla.
Yeah. Yeah, you turned me on to the embrasure wire thing, and I'm kind of just doing it on in every case now. Like it's just I
It's
don't know
solid,
if
right?
I don't know if it's just the sense of comfort that it provides me that things are really socked in. When you and I talked about it a while back, it was mostly like if you feel like there's premature contact or heavy or first contact on one side, do it on that side. And I'm kind of doing it between sixes and sevens and at the midline,
Yeah, because
every case.
embrasure wires, I think if people are, for a person is listening, embrasure wires from trauma, it's 6-7, from the facial to the palate, lingual in the mandible to the facial on the mandible. So just one wire that provides vertical force. Um, I don't know. I like it because it seats the posterior teeth. She's got brackets on her sevens. I don't know if she has a band or not on the six, but you don't need any of that. I don't trust those bands or brackets, to be honest. And so being able to seat molars into the intermediate splint or the final splint's like the beauty of it.
Yeah, and then a lot of our cases are clear liners.
Yeah. Because I mean, I just mainly used it in clear liner cases or liner cases, sorry. And then I was asking myself, why aren't I just using it in all my jaw surgery cases? And yeah, I mean, I'm like you in that I use it. I can't say every case, but very routinely, like most cases.
This may take us a little bit off topic for a Lefort talk, but why you and I are talking about why we each tend to prefer mandibular surgery first, despite I was trained mostly with maxilla first, and I assume that's kind of how you were trained as well, or is that not the case until you
Kind
went
of,
to
I trained at Oregon. Oregon was very much cancer trauma, TMJ. Orthodontic surgery was happening, but I mean, it would be different training than what you received at UW, right? Like there wasn't any there was um I would say I had one or two faculty that I would consider to be orthodontic surgeons, that they had a focus in that. Um and they had opposing viewpoints on maxillary surgery first or mandibular surgery first. And so when you're a resident, it's like, what do you do? In Charlotte, we did mandible first nearly, I don't want to say always, but almost always.
why do you like mandible first? Again, because most people maybe are not familiar with why you might even entertain the idea of mandible first.
I mean, I would hope most people are doing mandible first nowadays. I think
Think so?
for me, the main thing is I don't trust my records, right? Like I don't trust my bite record, and I don't trust the cone beam and my bite record being in the same position. And so if I'm planning the surgery based off of records that I don't really trust, then I'm just suspicious of the final result being inaccurate. And so the maxilla is really dependent on the mandible position in the plan being the position in the OR. Um, Obviously, you can do bone-borne guides, but my opinion on that stuff. So,
No big fan of custom guides and fixation.
well, it's fine in its place, but um,
Yeah.
I just think there's too much. There's just too much cost and too much workup and everything for otherwise straightforward operation. Um, I think the concern that the mandible is going to explode. I think that's probably like you're doing a sagittal osteotomy. You're just worried about not finishing the splint or not being able to achieve fixation. I think that's the anxiety that's present with doing mandible first. Are you past the stage already or no? Or you still haven't?
I don't know that maybe I'm just not even smart enough to have entertained that idea, or maybe I'm just,
Well, there's a concern that, if you can't get fixation or you can't split the mandible, then you basically just have to close up and the case is over, right?
right.
Like you won't be able to carry out the maxilla. So I don't know, I guess with reps that just hasn't borne out to be all that true. And
Are you
then
saying that's a pro or a con,
of
though?
mandible first,
Yeah.
I think it's a pro. I think the
Yeah. I mean,
concern, yeah, that
that's
it's
how I
not going to
would
go
take it, but
well isn't a case.
hearing you say it, it almost sounded like a con, but I was like, well, yeah, it kind of sounds like what you would prefer.
Yeah, I mean, I prefer to do mandible first. I just think the concern for why people do, I guess, yeah, you're right. I'm saying it wrong. Sorry about that. Um, and I don't know. I think most cases the intermediate splint with counterclockwise rotation makes more sense. Mandible first, for the reasons we talk about with fixation. Because orthodontists are like us. It's harder to do stuff in the back of the mouth than the front of the mouth, and so brackets in the front are generally solid, but in the back, it's pretty hit or miss. There's big tongues back there, and their teeth don't fit, and they're just trying their best like we are. And so if brackets fall off on the molars, just makes the day worse. Um, so yeah, I mean, I would say in your case here, I would entertain it though. Maxillary surgery first, I don't think is bad.
No, I don't think it's inherently bad either. I mean, like I said, I mean, for the first few years after I finished residency, I was like the thought of doing mandible first was just like lost on me. It's just all my reps came from maxilla first, and so it's just the familiarity, with it. I didn't even do it, but yeah, I would agree, and I think we're going to be saying the same thing here. But I was talking to some residents that I work with the other day, and I was trying to explain to them why I liked mandible first, and the way I look at it is just as you said, but maybe again another way of saying it is, yeah, the mandible can move. And so you're getting your bite registration, that record may be wrong. You get the CT, that record, depending on how they're biting, may be wrong. And they may both be wrong from what you see in the operating room. But if you have a fixed maxilla that can't move and you try to set your intraoral scan, and again, here comes the benefits of in-house planning. When you're tethering the intraoral scan to the maxilla, that's what I try to align, because sometimes they don't align perfectly. So I try to align it as well as I possibly can to the maxilla. And then if you do mandible first, you should be getting a fairly accurate record because the maxillary position can't be changed or altered. And I think there's probably two on articulators to an extent. The further you get along in the process, the less accurate your records may have been.
Yeah, I think the other situation I know we've talked about it is just midlines, right? So problem with mandible first is you can get the final midline off, which is legit. So it's differential seating of the condyles because it's super hard to figure that out during the surgery. Like the way you observe midlines and the first contact in evaluating your intermediate splint position and mandible first, I find that to be tricky. I mean, because I don't know, like anyone, you can lie to yourself, like you're viewing it from the side, so you're kind of looking at it wrong. I go to the top of the head, I ask other opinions of people. I have different pictures printed out so I can see it the way I would see it. I know that sounds strange, but I want to ensure that it's as accurate as it can be. So
No, I
I
do the
don't know.
same thing. I go to the head and then I try to lean over from the inferior, all those things. I feel like I'm overly paranoid and it angers the operating room staff how long I look at them sometimes.
Well, let me throw out a curveball on you here. So one of the things is the arguments for doing mandible surgery first is that mandible's the harder jaw. What if I said the maxilla is the harder jaw?
You and I have discussed this before, and the way we previously discussed it is I always said I would rather do a Lefort than a BSSO. And my rationale is I just always feel like there can be that wiggle with the mandible. You're seating condyles, and if you even seat them slightly different, you have that wiggle room, and that's one of the things that does kind of scare me about mandible first.
So you're saying mandible is harder?
I think so. I mean, I think there's a lot more that can go wrong in the sense of nerve injury, bad splits, difficulty fixating. I'd say it's rare that in my career, that I've had to remove fixation from a maxilla and refixate it, but I have done that several times in the mandible. Is your experience different?
I mean, I just had a Sag last week. I had to remove it twice. So I mean, it definitely happens. That I can't remember last time I had that happen, but
What about in the
literally
Lefort though? I mean, are you, to me,
in a
frequently,
Lefort, it definitely happens for sure. I mean,
I feel
because
like that rarely happens to me,
I,
and
I
maybe
don't
it's
know.
just
I
dumb
with
luck.
time I've come to appreciate the complexities of a Lefort. I mean, because when you start doing jaw surgery, your first time doing it as a one or as a junior resident is cutting a Lefort. They're like, oh yeah, you can cut a Lefort. Yeah, who cares? Like you're not going to run into too much trouble bringing it down, just kind of design. I remember thinking this was straightforward, and then mandibles were tricky because, like conceptualizing a mandible in 3D space and understanding how the split is going and knowing how to troubleshoot it. There's definitely a trick to all that. Um, but I think once you get past that trick, the maxilla is hard. I find the maxilla to be hard. Segmental Leforts are hard. Um, I think that freeing up those segments and making sure there's no interference to the pterygoid plates, truly passively maintaining in the transverse dimension, changing the angulation of the anterior segment, maintaining vascularity. I like to maintaining vessels, keeping teeth from becoming discolored. Those are real things. Generally, people, if they're going to have dissatisfaction and face change, is going to be around the nose. So manage the nose, manage the smile. I think Lefort's tricky.
I don't think there's any doubt it's tricky. I guess, and the other part that has to be mentioned is that you just do some insane cases. But I would say to you, single piece maxilla versus BSSO without a midline split or a chin, and you're moving them both 6 millimeters. To me, I
Forward
feel
or
like
backward?
that's forward. I feel like
Yeah,
that's
it's gonna be easier
fairly,
in the maxilla.
what's that?
Yeah, it would be easier in the maxilla.
Yeah, I think that's just yeah, when you start talking about segments, and I've seen some of your 5 and 6, 7 piece maxillas, you start talking about that stuff and moving them 15 plus millimeters. Yeah, I would agree with those sentiments, but I think the average BSSO versus the average Lefort, I feel
Well,
like
let's look at your case. Let's look at this one right here. Like click off for soft tissue, and then well, like imagine that you aren't doing a chin. Um, can you do the cartoon of what's going on here?
you want to do the videos that you
The
mean, like that?
video, yeah.
Yeah,
Can you just rotate it around while we're looking at this thing?
in the AP view, like this.
Yeah, sure. Just let's just see. I mean,
See it in all dimensions, is that what you mean?
all right, looking at her mandible, it doesn't seem that bad. I mean, mandible, reasonably good height. Didn't look like on your x-ray that she has wisdom teeth. Is that right?
Is not.
She's got pretty thick ramus, so not too much trouble there. Clockwise, if you do mandible first, it's going to be an interference party, which you'll have to manage before you put her in the intermediate splint. But fixation should be straightforward. She has stretchy lips. I think the mandible is straightforward here.
A little
What
bit
do
of
you
a high lingula, but not crazy.
think? Maxilla, what's going on with the maxilla, like from below? Is she getting real wide?
Not real wide, no. I didn't measure it in this plan, but it's not much. I probably actually would widen her a little bit more when I look at her. Stop this. When I look at her posteriorly, could probably give her a little more width on this side here. We're probably okay. But
That's
maybe
not her final occlusion there, though, right?
it likely won't be. This is what I plan just to show her and the orthodontist what I'm, considering and visualizing and what we need to do and change to get ready for surgery.
Considering some crowds on the sevens.
Maybe.
I'm joking.
Well, no, I mean, she does. She has this kind of unusual
No,
step in
I know, I know.
because of the
The teeth
buildup.
are bumping. I'm
Look
just
at that.
uh yeah,
Yeah.
no, I know this is like a rough initial virtual plan. Um
But I think I'd give her some more width here.
yeah, totally.
Relapse. She's got some flaring.
Tipping those things down. So I mean, you what's your incision like for a maxilla? Where's that?
I'm usually kind of between canine and first premolar, or I probably cheat over a little bit more. I kind of go back and forth from trying to make it as small as I can to feeling more comfortable. So I'd say I just go to about the first buys side to side.
Yeah, I'm probably making a little bit of a smaller incision, which can make life hard, right? So I'm probably doing canine to canine. But From incision standpoint, I think that's fairly straightforward in her. I think dissection, it looks like her maxilla is going to be thin.
Mhm.
Like the anterior maxilla looks pretty thin, her buttresses seem pretty thin, which means that you got to control your saw. And then when you bring the maxilla down, it's going to be prone to fracture, right? Like when you spread it either with the Smith spreader or with your hand or, whatever, um, the walls of the maxilla, once they start breaking, you start losing points of fixation. And fixation is really the hard part here. I think with her coming forward and clockwise, mobility of the maxilla, like getting that to be as mobile as possible is going to be very important, which of course makes fixation of that very mobile object an important thing. And I don't know, I think fixation is something to think of when you start cutting the maxilla, right?
Yeah, definitely. And then I think that takes us to another important topic that you and I discussed ad nauseum, and that's how do you mobilize the maxilla? I think most people either use, disinfection forceps or the Tessier's. You're a big fan of the Tessier's. I mostly use the disinfection forceps.
Huh.
Uh, One of these concepts, again, where it's strange that reasonable people, as you say, do same operation fairly differently.
Yeah, no, I mean, there's some variation, I think, in terms of where the osteotomy is in the anterior maxilla. I mean, but it seems like everyone uses a saw or piezo. I mean, I tend to dissect right, left, cut right, left. I do that subspinal or the subnasal osteotomy to, you know, release the nasal spine rather than strip, take off the septum, pterygoid behind the maxilla. You go transmucosal for the pterygoid
Yeah, I do the
attachment
UW
still?
way where we basically go transmucosal and anterior to the plates.
You should explain that to the non-UW people because that's kind of crazy. That thing freaked me out when I saw you UW people doing it when I moved to Seattle.
You need to embrace it.
I mean, I'm not opposed to the idea, just, can you take off the mandible from what we're looking at and point it out?
Uh,
Because making another incision behind the maxilla is crazy.
how do I? Do you know how to take? Can
Just
I
go to show
show
segments, select,
segments? I
and
guess
then
here.
get rid of
So
the
let's.
mandible. Just click mandible. There you go.
Yeah.
Yeah.
So traditionally, the osteotomy is pterygomaxillary disjunction at the level of the pterygoid plates, which don't show up real clearly here. Basically, kind of back here. When
But
we
you go
discuss
from inside the mouth. You don't go through your incision for the Lefort. You take a straight osteotome through.
through basically this area, just kind of go, make sure you leave enough bone distal to whatever the most distal molar is. And go transmucosal, don't even make an incision. So the osteotome makes the incision for you, an osteotome straight through here. And, with the finger on the palate, feel when you're kind of getting through, most of the time you can kind of hear it, feel it
Yeah. I mean,
go through. But
for me, it's the blood supply part, and then the fact that maybe fat could start pouring out, and I'm gonna be annoyed by it.
which is
Uh,
odd because the fat, for whatever reason, that doesn't seem to happen.
huh.
You get buccal fat pad exposure. Most of the time, I feel like that's the retraction or lack thereof or whatnot. But blood supply's never been an issue, even with segmental osteotomies. I've never had a segment die on me. Um, I
Yeah,
think
that might be a volume thing, right?
could be
Yeah,
or
I mean, because that's such a low rate thing. Actually, I haven't run into that myself either, but it's definitely a thing. I mean, because if you're doing a single piece or a two piece, but if you're doing a three, four, and if you're doing a revision, let's say three piece, it's like blood supply is a concern. But I'm not opposed to it. I just that concept of using an osteotome to make two additional incisions behind the maxilla is crazy. But at the same time, I'm more on board with incisions for wisdom teeth from below during a Lefort than I am from above these days. So uh,
when
I
you're
know
taking out
I
the
almost
wisdom
don't
teeth
want to tell you
from
that, but it's
you're taking out the wisdom teeth from in the mouth instead of coming down through the maxilla
I won't
after down
automatically
fracture.
take them from above. There's some wisdom teeth that are easier to access from below. Certainly, if they're partially erupted, it's just take them out from below.
Oh yeah, yeah.
So if they're almost partially erupted,
I
why not take them out from below? Um,
don't
because
know.
those are hard ones to get to from above. I mean, if they're deeply impacted and they don't have any roots, taking them out from above is just fine. So,
And are you doing that before the down fracture, I'm assuming, or are you
yeah,
just waiting?
exactly. Yeah.
Yeah,
So I'm hating on your incision and I'm giving an example of how I make an incision back there. So,
that's
um,
what I was kind of getting at there is, are
I
you
I
not doing the
realize,
same exact thing?
yeah, it is. So, I mean, I think, your way could be the right way to do it. The other one I've heard about is using a right angle, like an oscillating saw behind the maxilla, but I think cost and that sort of thing. But anyway,
No, that's a no for me on that one.
detaching the pterygoid, bringing the maxilla down. I use lateral nasal osteotomes on either side, and then use a Smith spreader, typically at a buttress, keep my finger on the bone to make sure I don't break anything.
So you're down fracturing with a spreader.
Yeah.
Hmm.
I'll bring the spreader. My most normal thing is to use lateral nasal osteotome on the left, then use it on the right, and then use the spreader on the alar rim on the left. And then that should.
Hold on, let me stop you there because I think I do the same thing as far as the order of operations here. But I was traditionally trained. You do the pterygomaxillary disjunction last in case you get a bleed. You've done everything else. You can just quickly down fracture. But I've kind of moved to doing what I think you're describing is the last thing I do is the lateral nasal osteotome before I try to down fracture.
Yeah, because I had heard that's the one that if that's where you get a bleed, you can jump at it. I mean, honestly, you can get a bleed either one.
Yeah.
I don't think it's all that common actually to run into bleeds from pterygoid disjunction, but descending palatine vessel definitely bleeds. That thing can get going. And the operation seems pretty chill until something starts bleeding and the maxilla is not moving, and then all of a sudden it can be stressful. And so kind of having the double suction going and good assistant and just kind of calmness through here. For me, at least, if the maxilla is not moving, it's usually because my pterygoid disjunction is not very good, or I didn't cut through a thick buttress adequately. Like my saw didn't go fully in the zygomatic buttress.
Are you doing the cut both ways?
Yeah, both ways.
Hmm.
It's just that, the length of the saw can be variable. At the hospital, they may not have the right saw. If they have the long one, then it's easy. But I don't always have the long saw, right? So if I don't have the tools I need, and I generally find when I have a short saw that those are the two spots that the maxilla is not moving down. Because once it starts bleeding, you want to get that maxilla down. Open up the maxilla. I usually use a rongeur, free up the nasal mucosa. And then Egber to harvest bone from the nasal septum or the septal attachment to the maxilla. I will then Tessier right, left, and then I Kerrison every time now. I start on the left, Kerrison the posterior maxilla. I've been getting into a little thin curved osteotome medial to the descending palatine vessel. That's
Wait,
nice.
explain that. That's new to me. What are you doing? You taking a
Rotate that thing around
osteotome?
and take off the mid face.
Wait, what? Oh, the picture.
Yeah, the picture.
What are you talking about?
Yeah, no, in surgery, just rotate the head around and take off the mid face. That would be easier. Can you take off the mid face in the same way we took out the mandible? I don't know. And everyone's got their different way to do things. But what I found is that if it holds up, it's holding up right behind the descending palatine vessels, right? Like the sticky part. So I Kerrison, so you would be accessing it from the opposite way, right? Like you're viewing it from the front. Yeah. Like, can you tip it down? Yeah, so it's can I use the cursor?
I don't know. You want to try? Where do you want me to go here?
Oh,
Here?
yeah, like on the descending palatine. So laterally, you can go with the Kerrison, pretty easy to snip off the attachment of the pterygoid. And you can feel if you have some of the plate associated with that. But medial to the vessel, if you want to maintain the vessel, I think it can be tricky, and it's hard to kind of snip adequately with the rongeur. And I've been getting into using a thin curved osteotome right there, because that almost always is what's holding up the expansion of the segmental Lefort. Because setting up the segmental Lefort is what I'm talking about right now. If it's a one piece, it's fine.
You're talking about this area essentially.
Yeah, exactly.
You don't just care. You feel like you have trouble kerrisining now?
So, can you rotate it? Keep rotating a little bit, like, yeah,
This
that
way?
way. Keep going, keep going, keep going. You see how it's like thin at the floor of the nose, and then it gets bulky as you get into the plate laterally. Like if we're snipping here, like that thick part, I don't feel like I'm very good at snipping off.
This part or lateral?
Right, lateral, right there, right
Yeah.
where your cursor is.
Okay.
Because yeah, snipping with a kerrison, I just feel like getting a curved osteotome or working that area is an important thing. Kerrisons free up maxillas like crazy. And I'm really not tessiating all that much. I mean, I do it just to make sure things feel mobile from side to side. But yeah, I think since the time we've done any surgery together, I've changed that quite a bit. That's a routine thing now.
Yeah, I mean, yeah, I kerosene, we were kind of trained and I've kind of kerosene this like crazy and then a little bit around the vessel, but you're kind of just going crazy all around the vessel is what you're describing. Like you're
Definitely.
working a lot.
Yeah, I
Do
mean, in
you
the
carry
past we've
that,
just
do you carry that on like this anteriorly? Do you like, the floor of the nose? Are you kerosening using the kerosene?
to get off the pterygoid plate attachments. I mean, because
That's
I've
it.
never quite
Yeah.
convinced that I've separated the pterygoid plates entirely.
Yeah, the way you do it, how could you? That's why you got to go transmucosal.
uh yeah, I mean, I think that as it currently is, I need to kerrison. So especially in that expansion point. So, on the question on mobilization of the maxilla, this stage is generally mobilized. So then I do my segmental Lefort stuff. And then mobilizing the segmental Lefort, um, grabbing a kerrison right behind the vessel to pull it, it seems to be much more useful and flap friendly than, let's say, putting a wire around the sevens or the sixes and pulling on it.
Oh, yeah.
Like um, controlling the segments when you expand a maxilla and not tearing is a trick. I don't know. I find this to be harder than BSSOs. You don't? This is all straightforward.
I think it depends on the magnitude of the movement. If you're really trying to get a lot of width here, or you're really trying to tilt some segments, if you're trying to make the teeth fit, if your setup orthodontically is not great and you're really using this segmental to really make the teeth fit, there's some major tilting and expansion. Yeah, I mean, I think it is. It's not only challenging, it's time consuming because you have interferences everywhere sometimes. Sometimes it's between the segments if you're trying to tilt or angulate and you've got to remove bone a lot of places. And sometimes you're worried about roots and other things and tearing. So yeah, I think if you have a straightforward single piece Lefort or a two piece with just, 5 millimeters of width increase, I don't think that's all that challenging. Most of the time. Now, have I had issues? Have I run into complications? Absolutely. But I feel like again, how many times do I refixate a maxilla? And if my palatal splint fit and other things, I feel like that's a pretty rare occurrence with most movements compared to the
Yeah, I
mandible.
mean, it's not common. It's just that, let's say we got this maxilla mobilized perfect and all is fine with vasculature. We're able to maintain the descending palatine vessels. Are you maintaining those or are you taking those, by the way?
I never cut them unless they bleed. I maintain them every time, uh,
Um,
unless I need hemostasis.
yeah, I mean, that's definitely different than I learned in fellowship. We used to always take them. I mean, always go out of our way to take them. Um, and I have changed from that. So I'm more in line with how you are. Um, mainly because of tooth discoloration. I forget, I was trying to pull up. It's a Korean paper, and it showed that with sacrificing one or both of the descending palatine vessels, you get discoloration of a tooth at a much higher rate. It was roughly a 1 in 50 thing, 1 in 50 people who go through a Lefort if you maintain the vessels. But it was as high as like 8 or 10%. Like, 1 in 10 is a lot. And a lateral incisor being gray, when you get out in practice, it's a pain in your ass. That's a
And
real
did you
deal.
see that? Is that consistent with your experience in your fellowship though? Did you see tooth discoloration?
At that time I was still learning things. I saw discoloration, but I just kind of chalked it up to that's how it goes with surgery.
Yeah, it's on
Right?
the
Like,
consent.
like numbness. Hey, you're having a mandible osteotomy. That's how it is. It's like, and so it's not like I'm saying it's a bad thing to take the vessels. It's just it makes a lot of sense to keep them. I remember as I was thinking about this, there's this old paper that Dirks had sent me long ago, and it had to do with the blood supply lost in taking the vessels. Um, and I can't remember what it was, but it was something like 80% reduction or something with taking the descending palatine vessels.
It just, I don't I mean, I mentally understand the rationale. I, I don't, I cannot recall significant bleeding just occurring, from leaving those. Like I think the concern over taking them because they may bleed post-operatively or what other circumstances, that I just haven't seen the manifestations of that. I'm sure it happens, but
Yeah,
like
I mean, yeah, so maintaining the vessels, I think we're both on page with that, but it becomes a fixation problem because fixation of maxillas is tricky. You put a palatal splint, graft it, bone is questionable, and it's prone to run into healing trouble after surgery. People grind their teeth, people swallow, blow their nose. There's just kind of a
they
number of
projectile
things that
vomit.
happen.
As I
What's that?
told you about that case I had a patient projectile vomit, and it seemed to move the maxilla. Uh, yeah,
Yeah, I mean it's not a very stable construct in general. And so a thinner case like this, like you let's go with the assumption you could get everything perfect with mobilization. Getting it to heal in that spot is a bit of a trick because it'll be prone for a posterior open bite, it'll be prone to drift back narrow. Segments will be prone to tip, like bonding composite in between the cut arch wire, palatal splint for a longer period of time. You can do everything you can, but I generally think there's more variability in maxillary healing than there is mandibular healing. So I think that's why in an aggregate, I wanted to see if I could convince you that maxillas are harder than mandibles. No, I didn't. I didn't have any success.
you did not yet. I mean, I think this is one of those cases where sounds like we're disagreeing, but we're probably actually agreeing like 95% of the way here because, again, I would say bigger movements, more segment tilting, truly trying to make the teeth fit with the Lefort level of complexity in your segmentals. Yeah, I think that's a much harder operation. But if we're comparing apples to apples in the sense of single piece mandible, single piece maxilla, reasonable movements, I just no risk, really minimal risk of long-term numbness, you know,
All
other
right.
things. I mean,
Yeah, no, I mean, numbness will
whatever.
happen at the roof of your mouth.
What's that?
Behind the centrals, it'll be numb or paresthetic.
Oh yeah. They don't care though. They just don't care.
You'll meet somebody who cares.
I probably will. What are you using for fixation? What diameter plates are you using? Or what level of plates are you using? How many? Every
I use 4 plates, 16 screws. I try to span the segments. So to get 2 screws in that anterior segment. Um,
you using 1.6, 1.7, 2.0?
so I mean, I've been on a quest of using fixation for the last 4 years. I'd used Striker for a decade plus. Then my hospital did away with that. So I've now had the experience of using Zimmer, Synthes, and KLS. In my office, still use Striker. At the hospital, I generally use KLS though. And so KLS, what I'm getting at is I can't really remember what size everyone is. I think I use the 1.6 or 1.7s in the maxilla, unless it's a big advancement, like like a
You're using that
15.
everywhere,
Yeah.
all four
And then
plates?
I'll use a 2.0, like those gray diagonal plates for KLS. So
Wait, so hold on. You're using 1.6 or 1.7 anteriorly and 2.0 posteriorly, or what are you saying there?
1.7 both or 1.6 both.
So when do you
All
use the
four.
two? When were you saying you're using the 2.0?
Big advancements.
Oh, big advancements. Okay.
Yeah, like if it's coming down, I generally entertain custom plates in that scenario. But big advancement, with like MMA case, where MMAW, where there's 12 mm shelf or
MMAW, what's
something.
that? What are you saying? MMAW, nobody
Wasson,
knows what
you
you're talking
love
about.
MMAW. That's a great operation.
That's a topic for another day.
That's
Well,
for
I'll
another
tell
day.
you, the way I was trained was thin plates in the anterior and then 2.0 in the posterior, out of fear of feeling or thinner skin here in the anterior and that being noticed. I think I've actually transitioned to the opposite theme where I use all 2.0 unless the person is very thin, like thin females. Typically, I will use 1/7 in the anterior, 2 O's in the posterior, but you get that one malunion case every so often, and I immediately am like, why didn't I use all 2.0?
Yeah, but I mean, do you think it's really the plate that's the trouble with those? Because for me,
I
it's
don't
the
know, but
screws.
that's
The screws seem to fall out. Screw
you know,
mobility seems to be the thing. I mean, I've heard of plates breaking, but I feel like plate breaking is more end stage non-union, right? Like it's had a non-union for so long that the plates just sit there and
have mechanical
materially
failure
weakened
over
and it
time.
broke
Yeah,
finally. But I don't think that's like the eliciting factor. I think it could probably, because it's cantilevered tip, right? Like those segments can tip a little bit more with weaker fixation. Um, but I think generally the downside of 2.0 is that the screws are so dang big. Like the the size of the screw takes up more space. And I mean, rotate that lady around. It's going to be tough real estate finding a spot, above the apex of the canine or above the lateral for a screw. I mean, this situation actually she seems okay. Um, but I can envision a time where you may not want to put a screw in that exposed mesial buccal root of tooth number 14 over there.
why not?
I mean, you want to just put it.
That's more
I
cortex.
mean, that root's gonna be staring you down. And so, it's kind of like you got to dodge the area. And so drilling a bigger hole, I don't know. I feel like that's not a make or break thing, but it definitely is a thing. So
Yeah, and you're not using any pre-bent plates.
no, I can't say any. Just when the Maxilla comes down. I mean, the idea of using custom plates all the time.
Not even custom, but a lot of companies have pre-bent,
Oh, sure. Yeah.
incremental plates.
Yeah. I mean,
I'm
I
a big
think
fan of those.
semi-custom makes much more sense than custom.
Say that again.
Semi-custom makes more sense than custom.
I wish they made, and I've talked to my striker reps about this. I may need to try to float it up higher levels or push for it a little more. But I mean, I don't know why they don't have pre-bent, or I haven't seen them. Maybe they do. The pre-bent, just like L-shaped plates. Like all the pre-bent ones are the crazy
Yeah, I was trying to
T's.
convince them to do that, but I think the companies are very pro custom plates and all that sort of thing. I think what we're generally speaking to, which is good to hear from you in this way, is that, fixation and maxilla isn't just the same. Like I always do this. In every case, I do this.
I
It's
mean,
like
and
customizing
we
to the
both
situation.
changed. I think the other point is we both changed, and like it wasn't like we were getting catastrophic results in our old ways.
Yeah, but I mean, sometimes different things make sense.
Oh yeah.
And so, having a few things in your repertoire, I think, is a useful thing. Let me uh to finish up the Lefort talks, I got my thing I got to go to, but talk me through Ayler cinch.
Yeah. Are you still let me ask you, are you still doing that even though you're doing the subspinal?
I am, yeah.
I'm doing both too. I mean, I've only done the subspinal a handful of times too, but I'm just paranoid and I do both. Even though a lot of the paper, or like a couple of the papers I read comparing them, they made it sound like when they did subspinal and no alar cinch, that they got better results than an alar cinch. I mean, that's kind of, I guess, the whole point of doing it. So
Well, I mean, I generally think of to describe, if people don't know what we're talking about, making an osteotomy underneath the anterior nasal spine to keep the tip of the nose on the bone
somewhere
rather
along
than
here, this isn't
stripping
the
the
best
ligaments.
thing. She had a piercing that kind of distorted this a little bit, but
Sure.
kind of
But
along here.
I generally do that for tip rotation, like management of tip rotation, right? I mean, in terms of width, it probably helps with it. I just, I've been kind of getting into resuspending musculature of the maxilla, pretty similar to how you'd approach a chin incision. Um, and generally, my Ayler cinch throws that off, right? Because it overcorrects that. Um, Conventional wisdom is that you need to place it, though, even though I think if you talk to people who do some volume, there's more uncertainty on this. Um, I think this is an area that I could see changing in the next, let's say, 3 to 5 years in my world at least. So
What you're
hopefully
doing is
I can listen to
resuspending
one of your
muscles and
talks.
not doing alar cinch? Are you saying you're experimenting with that? Is
An
resuspending
alternative to that. Yeah, like resuspending musculature instead of alar cinch.
and
Uh,
so subspinal resuspend muscles, leave out alar cinch.
yeah, I'm currently not doing that. I'm currently still doing alar cinch, single muscle resuspension stitch, and then either straight or VY closure, depending on the situation.
Yeah. Yeah, I mean, I guess to answer your question, I'm pretty much I'm doing subspinal when it makes sense. I have one coming up. I might show you that just the roots of the teeth are just so close that I mean, the angulation of the subspinal is going to be wild. Where I'm just wondering, like, is it worth doing? And I'll just do my alar cinch. But yeah, alar cinch. I think if we were trying to say how is it done or explain it to people, it's basically trying to go through the lateral. I guess here's the other question. Are you trying to go through the cartilage or are you just trying to go through the muscle and soft tissue?
Yeah, just going through transverse stasalis, I don't feel like I try to get some bit of cartilage. I don't know, there's just different noses, right? It's very much an art and a feel thing when it comes to that. And then there's the damn nasal endotracheal tube in there.
If you
I don't feel
have
good
one.
about that part of the maxilla. I still don't feel great about pterygoid disjunction. I mean, I can obviously do it. I just feel like it's not as clean as it could be. And then
I've given you the solution and you just refuse to use it.
transverse nose. I mean, like, because you when you're learning, it's like, hey, you got to
I will say,
do an alar
and
cinch, but there's nuance to it.
oh, no
Like any
doubt.
of this, there's nuance. And
And I think
so,
doing things uniformly, as we've kind of said in other avenues of just saying, here's what I do every time is not appropriate.
yeah,
But the other point to maybe advocate for Mandible being easier to be my own devil's advocate is these types of things, and I kind of feel
wait, didn't you say
post-surgery.
mandible was harder?
No, well, that's what I was saying before, but to kind of maybe even make a point to your position of maxilla being harder, I would say these are the things that make it more difficult. And I would add in there, I always feel like people who I do Leforts on, or people who have had Leforts, when they walk into my office, I feel like you can almost always tell. And
Yeah,
it's the nose and the upper lip.
yeah,
And you can just look at them before you've seen an x-ray, before you know history. You
yeah.
see
You're probably
enough
seeing a
of
lot
them.
of clockwise rotations though, but still, I mean, like that when they're unable to control their occlusal plane regularly. But I mean, I know what you're talking about. Yeah, and in real life, I can see that stuff, and so man, it'd be nice not to have that. So I feel like there's a way.
Good luck. I mean, I don't know. I feel like that's the struggle is their lip mobility and movement, the position of the nose, like it's fine. And to lay people who don't look at it all the time, I don't know that those people know, but like I feel like I can spot it a mile away. They
Yep.
walk into the waiting room and I can almost smell it from my office. Like, oh, I can see it. I just know it's there and it bothers me. And I don't know what the solution is to it, but
Yeah, it's a
maybe
big
it's
operation.
resuspending
I mean,
muscles.
Laporte's a big operation. So
Yeah.
I mean, both are.
All right. Well,
Uh,
let's wrap this up. I know you got stuff to do.
well, it's always fun talking with you. I just gotta plan some cases.